Okay, so welcome to everyone who's joining us online. And let's first off, we gotta get, I think we're in focus up there, so now we gotta focus down here and everyone get their eyes in. Everyone good?
Mm-hmm.
Okay. So, Shane, where on the body do you think we are?
It's acral. It's kind of maybe a little fluffy, superficial.
So it's acral, and what you don't have is you don't have big papillary dermal edema, which you often get in perniosis. So perniosis is in that differential with Sweets and polymorphous light, where you get a band of papillary dermal edema often, and if you see that on acral skin, you're pretty much done that it's perniosis. But what you do have is you have lymphs, and every lymph sits on a background of white, right? And that's the so-called fluffy edema of the vessels. So this is a good example of it, where every lymph is discrete, they're not even overlapping, and there's extra white sitting around it. And for some reason, the new images are not capturing up on the screen, which means Panopto is probably not working. Okay, we can't worry about that today. But so you are correct. That is most consistent with perniosis.
The EAC, like coat-treating, do they ever get the fluffy edema?
Not so much, and EAC to be on acral skin like that would not be likely, right? So EAC would rarely be, I mean, it is a pretty tight pipe stem or coat sleeve pattern of lymphoid infiltrate, but you don't get the papillary dermal edema, and it's not on acral skin, and you really don't get so much the fluffy edema.
What about Chilblain's lupus?
Same. Chilblain's lupus is just perniosis.
Okay.
Yeah, it's just, 30 to 50% of perniosis patients turn out to have lupus. So every patient with perniosis gets an ANA and a workup, because it's often how lupus presents. Okay. So, Caleb, here just in time. So, what do you see? And you need to come to the scope, because that's not changing up there. You'll be looking at the same image the entire conference if you stay where you are. Okay, I'm sorry, Caleb.
Like a patchy perivascular kind of infiltrate.
Yeah, so patchy perivascular kind of infiltrate.
I was wondering if on the first.
Where on the body do you think you are?
Maybe acral skin?
I think I'm thinking probably not acral, just because the corneum's not quite thick enough.
All right.
We may be like dorsum of an arm. We could even be a hand.
Okay.
So I guess acral is in there. Certainly not volar, but acral.
Mm-hmm.
And then there is some fluffy edema. So, this is exactly what David just brought up. I mean, this one is billed clinically as PMLE, but I'm not sure that you could say this wasn't perniosis. So for this one, you'd have to have a differential. So this is probably the exception that proves the rule. That's as fluffy a PMLE as I've ever seen. It certainly looks just like a perniosis pattern. Apparently, clinically, this patient had polymorphous light. I think this slide easily could represent either one. You'd have to know what the clinical was. Perniosis tends to be more tender than itchy, although it can itch. And the PMLE tends to be way more itchy than tender. And I think we do have more heads up here if you want to join. Because that's static on one image forever. We also have new set of trading club. Okay. And Beth wrapped in one of the slides back. And does anyone use pocket organizers anymore? Like pocket calendars?
All on the phone now.
Yep, that's
I didn't think anyone, I mean, there is one here. If anyone wants it, you're welcome to it.
Thank you.
Okay. Okay. So, Rachel, what do you see?
So I see a lot of
What are these
like
red
mixed,
cells?
those look like EOs.
Yeah, so it's a mixed perivascular
Yeah.
infiltrate with lots of EOs.
And then there's also some up in the papillary dermis.
Yeah.
Um,
And tell me about your endothelium.
I
Do you see a lumen?
No.
So that means the endothelium is
Not
swollen.
open? Yeah.
Yeah, swollen. So swollen, what you don't see is big endothelium. What you see is absence of lumen.
Right.
Okay, so that's swollen endothelium. So pretty dense, superficial and deep lymphoid polymorphous infiltrate with endothelial swelling. You usually think of. Anyone want to jump in? Yeah, bug bite. Right, so that's arthropod. So superficial and deep, wedge-shaped, dense infiltrate, polymorphous endothelial swelling is bug bite. Okay, and then what do you see here? What's this thing? Where you got all these red eosinophil granules on the collagen.
Is that a flame figure?
That's a flame figure, right? Is there any granuloma surrounding the flame figure?
No.
No. If there's granuloma surrounding the flame figure, what do you have? Church-Strauss. In the absence of granuloma, then it's Wells. And what causes Wells?
A bug bite?
Yeah, Wells is a fancy bug bite. Or in this case, patient turned out to have scabies. So Wells is any kind, which is why we say arthropod reaction. We don't say bug bite because it includes scabies, right? Includes stings, bites, burrowing things. So it's just arthropod in general. So this is Wells. In this case, turned out to be caused by scabies, but all Wells is basically some kind of arthropod reaction, just exaggerated. Okay, how about this?
So this almost has the. Are these flame figures?
They are flame figures, with granuloma or without granuloma.
It looks like they might have granuloma.
Granuloma would be pretty obvious.
Okay.
Yeah, so they're without. So this is
Wells syndrome.
Wells syndrome, and what is Wells syndrome?
Arthropod.
Arthropod reaction, and we say that just because it's not always a bite. First off, what's wrong with the slide at low power? What's all this red stuff?
Yeah, it looks like there's RBC extraction.
And is it an inflammatory purpura? Do you see any inflammatory cells?
No.
So that would make it
A non-inflammatory.
non-inflammatory. So what's your differential for a non-inflammatory purpura?
There's scurvy, and then there's senile or solar purpura.
Scurvy, solar, what else?
Uh,
Anything with thrombocytopenia,
mhm,
right? Trauma.
mhm.
So ecchymosis, thrombocytopenic purpura, so ITP, TTP, things like that. Now, are the vessels in this one normal, or is there something in the vessel?
Looks like there might be a thrombus.
There's
in
a
the
thrombus
vessel.
in there, right?
Mhm.
It stains really bright. Remember what the center of a rheumatoid nodule stains like? That really
Fibrin,
intense
red.
red fibrin.
Mhm.
This is that same red, right? So that's a fibrin thrombus sitting in the vessel. So now you've got fibrin thrombi and purpura. What's your differential?
You can have TTP.
So TTP,
Or-
thrombotic thrombocytopenic purpura, which is usually toxic E. coli, right, from bad hamburger. What else?
I think ITP is also.
Like hemolytic uremic syndrome
Right.
is a lot of the TTPs that we see.
Idiopathic thrombotic purpura is also up there.
Well, ITP doesn't have a thrombus.
It's thrombocytopenic.
It's thrombotic. The difference between TTP and ITP is the first T, which is thrombus.
Okay.
Okay, ITP,
TT.
you're missing platelets, so you bleed, but there's no thrombi. But things like DIC,
Right.
and then clotting disorders, where you don't fail to clot, you have too much clotting. So what are your disorders with too much clotting?
For hypercoagulable states, there's protein C and S deficiency,
Yeah.
antithrombin 3 deficiency.
Prothrombin mutation, factor V Leiden.
Right.
So there are a whole list of thrombotic disorders: protein C, protein S, antithrombin 3, prothrombin mutation, factor V Leiden. Factor V Leiden, I think at Morning Kodachromes, we may have shown a picture of a 15-year-old kid with leg that's just all ulcers down to bone. He's lived like that since he was 5 years old. That's factor V Leiden. Yeah, it's pretty nasty. And you clot and tissue dies. So that's pretty good differential. So the non-inflammatory purpuras.
So it looks like there's a little bit of papillary dermal edema and then possibly some those EOs or newts in the
Yeah, mainly
Vessel.
newts in
Newts.
this particular.
Yeah.
I did see a rare perivascular EO, but what's
Right.
in the vessel is mainly newts. So it looks like
urticaria perhaps.
urticaria, right? There's no Cariorexis, so it's not vasculitis, right? Vasculitis, the L in LCV is leukocytoclasis. So if there's no L, there's no LCV, right? So there's got to be fragments. What else looks just like urticaria histologically?
That's a good question. I'm not sure.
So there are a list of other things that look like urticaria. So urticaria, the neutrophils start inside the vessels, plugging the vessel, and then they go through the vessel wall and they're in the interstitium. They may be joined by a few EOs, but there's never any nuclear debris. So that's what urticaria looks like during its lifetime. But things that look just like urticaria, anyone? So stills. And what else looks... So that's acute stills. Later stills has dead reds in the epidermis, like incontinentia pigmenti, and then they move up to whorls in the corneum, like Starry Night, just like incontinentia pigmenti. So that's late stills. Early stills looks like urticaria. And what if I'm a kid who had strep and I have chorioathetosis and I have migrating urticarial rash? And this was a kid with E. marginatum after strep. But it looks just like urticaria, right? So the things, there are things that look just like sweets, bowel bypass syndrome, GCSF reactions. There are things that look just like urticaria. So if you have, you look at the slide and you say, urticaria, and then you look at your pick list, it's not there. So then the question, what they're asking you is what looks just like urticaria, which can be early stills, E. marginatum, they look just like urticaria. Okay, Derek.
All right. Looks like there's some perivascular infiltrate. Kind of look like there's some red blood cell extravasation.
Okay, so first off, what's that vessel?
That's a postcapillary.
Venial. And is that where most of the activity is, or is most of the activity above that?
Above it.
So what's above, this is a trick question, what's above the post-capillary venial?
The capillary.
The capillary! Yes, okay, so what's above the post-capillary venial is the capillary, right? So this is a lymphocytic capillaritis. So what's your differential for lymphocytic capillaritis?
The pigmenting purpura.
Yeah, I mean that's basically the category you're in, is pigmenting purpuric eruption. The one thing you have to remember is MF can look like that too, so make sure you're looking for subtle epidermotropism, because MF can really look like a pigmenting purpuric eruption. So you look carefully at your epidermis, no lymphs, no basilar tagging, so it's okay. So this is just PPC. And then to confirm the diagnosis, you're going to get an iron stain and see that it's chronic enough that you've had some hemosiderin there too. That's absolutely correct.
Alright, so they punched into this, and looks like it's got a lot of extravasation, a lot of inflammation.
So when they punch, were they most likely, with the exception of punching out a small dark pigmented lesion, when you punch you're usually looking for itis, not oma,
Right.
right? So, it's probably an itis question, but so is everything in this box. So.
Right. And, I'm trying to see if it's just the staining or if there's a lot of EOs mixed in throughout.
Yeah, I think there are a lot of EOs.
Yeah, so you could start to think about, like arthropod, it is mixed. A little
Yeah,
bit
so you
wedge.
could think about arthropod. What do you think about lumen?
Lumen looks like it's intact, so.
Yeah, so that's not so bitey, right?
It's true.
Bites usually have swollen arthropod, but it's definitely a dermal hypersensitivity response.
Right.
So what things are DHR that are not bite?
I'm not sure.
So what other things fall into the DHR, dermal hypersensitivity response
Itchy
category?
red bump disease. Right?
So itchy red bump, which is like you have bites, but you swear you're not getting bitten. That's pretty much what that is. Drug, absolutely. Drug and late urticaria. What else? Food allergy. So any type of hypersensitivity response. Drug, bug, and other allergic responses, hives, a late hive reaction. Now this one though, it's got a little bit of interface change. See that little vacuole there? And it's got a little bit of spongiotic. So it can't decide what it wants to be. It's got a little sponge, it's got a little interface, it's got a little dermal. So what are the conditions you're supposed to think of when it can't decide what it wants to be?
Then it's just kind of drug viral syphilis.
Drug viral syphilis for mixed patterns, right? And with all the dermal hypersensitivity response, probably drug.
Mm-hmm.
Very good. Okay, so Ying, what do you see here?
I see the conium of the lymphocytes and eosinophils, and some place. Oh, there is some like flame finger.
Yeah, very prominent flame figure, superficial and deep perivascular infiltrate,
So
endothelial swelling, no lumen there.
so it could be Wells syndrome.
Yeah, absolutely. So this is a Wells arthropod type of pattern. You've got a huge granulome, or huge flame figure, but really no palisading granuloma around it. So, it borders right on collagen. In Churg-Strauss, it would border on a thick border of histiocytes. So where do you think you are?
Looks like acral skin,
Looks like acral skin. Tell me
Looks
about
pretty-
your papillodermis.
edema, looks pretty fluffy, so perniosis.
Yeah, exactly. Perniosis from scan. So tell your patient stay out of the cold, go home,
Might want to check up for lupus.
because 30 to 50%. That's how their lupus is going to present.
Punch biopsy, some superficial papillodermal edema,
Yep, and then your infiltrate is mainly composed of.
mainly lymphocytes, in there, kind of a sweet C picture. Yeah, a lot of karyorrhexis.
Yeah, so lots of neutrophils, lots of karyorrhexis,
So
with
like-
massive papillodermal edema, so it's a sweets picture. So this patient does not have sweets. So what can the patient have?
So we could have gotten GCSF or bowel bypass.
So bowel bypass syndrome, which is everyone who basically gets weight reduction surgery can get sweets-like lesions. GCSF. What if it's all over the tops of my hands and they get kind of necrotic?
Neutrophilic dermatosis, or
Yeah,
dermatosis of the dorsal hand.
yeah.
neutrophilic
So you can say
dermatosis.
pustular neutrophilic dermatosis or just neutrophilic dermatosis of the dorsal hands. But this person, it was all over their body, and they broke down with an overhanging violaceous border and pitted necrosis.
Like a early PG.
Yeah, pyoderma gangrenosum, which in its early stage looks just like sweets. Okay. So PG is also in the differential for a sweets-like reaction.
Looks like maybe facial skin.
Yeah, we are on facial skin.
So in the superficial dermis, there are, so it looks like maybe karyrectic debris.
Yeah, newts and karyrectic debris. And it's not particularly around a vessel, is it?
No, it's kind of ill-defined.
Yeah. And I don't see a lot of papillary dermal edema, but it's certainly a neutrophilic infiltrate, and this patient was on Neupogen.
Okay.
So, it's just GCSF type reaction.
Do you have to have EOs for granular facial?
I thought
You-
about the dislocation.
Well, plus that should be perivascular.
Okay.
So GF should be a vasculitis. It should be perivascular. And I think it would be tough to call without EOs. EED may or may not have EOs, but GF pretty much always has EOs.
This thing kind of fell apart a little bit.
Yeah, not only that, but that's like someone was really enthusiastic with their forceps.
It's like some cannonball angioplasia. Maybe.
There is some cannonball angioplasia, making you think.
Like stasis dermatitis.
Yeah, at least you're on a shin, probably, and it may well be stasis was the issue, which was, in fact, the history. Well done.
actually, there's LCD, maybe this little 5.
Yeah, so there's fibrin. It's definitely predominantly the postcapillary venial. Right, that's you always have spillover to adjacent vessels, including the capillary in this case, but the big involvement is postcapillary venial, which sits right at the junction of the bundled reticular and non-bundled papillary dermis. You see all the red fibrin. You see that your endothelium is still intact. You don't, it's kind of hard to tell. It doesn't go deep, but there's certainly no endothelial necrosis like a big 5. So what are your little 5 vasculitic disorders?
We have HSP, mixed coagulopathy anemia, serum sickness, connective tissue disease, and
And while you're at it, what if you saw superficial and deep and endothelial necrosis,
then we'd be thinking about the big 5.
which are,
The ANCAs plus septic and rheumatoid vasculitis.
and your ANCA ones are,
Wagner's, Church-Strauss, and MPA.
yeah, microscopic polyangiitis. That's pretty good. So you just divided the world of vasculitis in half. You got a much shorter differential to work through.
So, I mean, like it's very pale staining, but I can see like vascular lumens.
And what's in the lumen?
And I think red blood cells. I'm not sure. Or maybe some fibrin or thrombi.
Yeah, so probably thrombi. You got, 1 or 2 neutrophils, but not a whole lot.
Mm-hmm.
You've got fibrin thrombi, and a lot of the fibrin is not in the lumen, but sort of in the wall, that the wall is thick and hyalinized.
Okay.
And they're in tufts like stasis, and in fact you see a lot of background hemosiderin. So you've got a background of stasis, and you've got these hyalinized fibrinoid walls without real vasculitis.
Mm-hmm.
And some of them, it's so narrow, it's hard to see how any blood could get through that.
Yeah, so are you thinking segmental hyalinizing vasculopathy?
So this is exactly segmental hyalinizing vasculopathy. What's the clinical name for what that produces?
Lividoid vasculopathy.
The or atrophy blanche.
Okay.
All the same thing. So atrophy blanche, which is where you get the little white atrophic scars, usually very painful because of the ischemia. Lividoid vasculopathy, because it's lipido pattern and you've got vasculopathy, not real vasculitis, or segmental hyalinizing vasculopathy, which is just describing the path. Okay, so that's your patient. Now what do you work them up for?
Like coagulation, hypercoagulable states.
So hypercoagulable states, but that's usually, this isn't going to be a protein C, protein S typically.
Okay.
So where does this fall if you're going to find something?
I'm not sure because I thought it was protein C, protein
Okay,
S,
so
but
anyway.
it wasn't.
So more antiphospholipid.
Okay.
And so first off, some can just be stasis, but a lot are antiphospholipid. A few are factor V Leiden, which kind of overlaps with your bigger vessel hypercoagulable, but a lot more likely to be antiphospholipid. And then a lot of them fall into antiphospholipid syndromes, including the women who lose babies and the people who have lupus with antiphospholipid who die of strokes and multi-infarct dementia. So, when you have atrophy blanche and you've got lupus, it's really bad. It's Sneddon syndrome, antiphospholipid, and you're going to die little by stroke after stroke after stroke, because the same thing's happening in your brain that's happening in your legs. So that is segmental hyalinizing vasculopathy. Very good. Okay, Sarah, where are you on the body?
Looks acral.
And what do you see?
There's a lot of inflammation in papillary dermis. Can't really see much deeper than that.
So papillodermis,
And then there's
maybe a little bit, in this case, a little mucin probably, more than edema. And then, is the infiltrate all neutrophilic?
no, there are lumps.
It's lymphoid, and the lymphs are sitting on a background of pink and overlapping? Or they're sitting on a background of white and very discrete?
They're sitting on a background of white.
Yeah, and very discrete.
Always the latter.
And it is the second one. So, and you do know on the board exam, it's also always the second one. Always B. You know that's total nonsense, right? Right. Okay, so limbs with surrounding white, acral skin, perniosis, and you're working your patient up for?
Lupus.
Lupus. Well done. Okay. How about this?
So we have pretty broad shade. We have RBC extravasation, and looks like
Tell me about the vessels.
they look like they're tufted.
So they're tufted, which tells you, first off, where are you probably?
Most likely on the shin.
Most likely on the shin. And is these normal lumen, or is that a lumen that's not much bigger than a red blood cell?
I think the latter.
It's the latter, and those, look how thick the walls are. Look how much amorphous pink there is there. So what would you call a segmental hyalinizing vasculopathy?
Probably atrophied bone.
Yeah, exactly. So, you know, that's how it earns its name, because this is a segmental hyalinizing. It's not a vasculitis, it's a vasculopathy. But the lumens get so small that the cells can't get through. Okay.
That's a lot of lymphs.
Yeah, lots of lymphs, lots of histiocytes, lots of necrosis.
Is that a
I'm not sure why this is in this box. That's a, that is a big caseous thing that looks like it should be mycobacterial, right? So that belongs in the granuloma box. Someone's been sloppy about what they've been doing, and that belongs in a different box. Okay.
so looks like I can't tell exactly what cell type that is. I was gonna say lymphs because they kind of look lighter than lymphs.
Yeah, they're kind of lighter than lymphs. You certainly have a few eos, and you got some newts, and you got a little neutrophilic debris, and you got your vessels kind of roughed up, and there are some newts and some Caryorhexis there, but the whole thing looks kind of weird, right?
I agree.
So, first off, you could think of drug with mixed patterns, you could think of viral, you could think of syphilis. History in this case would help. Is you've got someone who has genital ulcers, hypopyon in their eye, and they every time they get stuck with a needle to draw blood, they get a pustular ulcer. So that's Behçet's, yeah. Which we probably shouldn't call Behçet's anymore because he was a nasty character. So there.
Vasculitis guys were.
Yeah, he's the next one to. That's in the wrong box.
Is he like Rainer?
Yeah, apparently he was like World War I Turkish and involved with genocide, and yeah, so he's like a ne'er-do-well, unsavory character. So, one of the dirt bags.
Dirtbags and dermatology.
Dirt bags and dermatology. There's actually a book. That, it's not called Dirt Bags and Dermatology, but it should be. And Wires wrote it. And
Wasn't Wagner too?
yeah, Wegner was a Nazi, and
Church
Reiter was even worse. No, Church and Strauss, they were fine.
Oh, okay.
They were New Yorkers.
Gosh,
They,
Blake.
Sounds like opera.
Don't try to take away.
I didn't mean to sing their name. They went.
No, I actually researched it, and I could not find anyone who had a bad word to say about either Church or Strauss.
So composers.
Yes, exactly.
All right, so this looks pretty much like a deep vessel
Yeah, kind of
vasculitis
like a deep vessel,
with some
and
keratosis.
there is a little karyarexis. You know, it's not real advanced, but there are definitely some eos, some karyarexis. So you sort of wonder what's going on here. There's a lot of dense collagen there, and a lot of new vessel formation. So this is probably the late healing stage of a deeper vasculitis. So probably a big 5 type of vasculitis in the late stage where you still see vessel damage and you still have some debris, but the whole thing's healing. So, you know, this is a late stage of a deep leukocytoclastic vasculitis. So you'd need to check ANCAs, find out if they're healing after a septic vasculitis
An RF.
or rheumatoid vasculitis, yeah. Although rheumatoid vasculitis usually eventuates in ulcer. Okay, so this whole pile is things in the wrong box from whoever was reviewing slides and had them out on the table. Okay, slide's a little pale. But what's your pattern?
A whole lot of papillary edema, so just depending on the infiltrate underneath.
Yeah.
If we go down to sweets or lymphocytic type patterns.
Yeah, so if it's lymphocytic pattern, you might think of PMLE that looks like maybe even acral skin,
Right.
right? So sweets, or the other thing on acral skin, pustular dermatosis of the hands, those would all be your differential. But it's one of those infiltrate with big papillary dermal edema.
It says superficial and deep pervascular, pronexural lymphocytes,
Yeah.
and some mutations, and this is state of LE.
Yeah, absolutely. So this is tumid lupus. So, well done. Where's that easy button? Right there. Pass it over.
Thanks, sir.
That was easy.
So you got superficial and deep, lymphoid infiltrate. It involves the eccrine coil. So in the eccrine coil, you've got lupus, lymphoma, lichen striatus, Lewy, syphilis, with the eccrine coil. Mucin in the dermis. Now the child we had with neonatal syphilis had, or congenital syphilis, had mucin and looked like lupus. There was another, Sig Torgerson had a poster at the ASDP meeting that was a patient they diagnosed with lupus who had syphilis. Identical. Absolutely identical, except it was an adult. But it looked like subacute cutaneous lupus. The biopsy looked like tumid lupus, just like this, and it was syphilis. So, and there were other reports at the meeting of mucin in syphilis, so it's becoming increasingly recognized. In fact, there were 2 reports of plaque-like mucinosis, just mucin, as presentation of lupus. Or, I'm sorry, a presentation of syphilis. So. And that's in the wrong box.
The slide here.
Okay.
Looks a lot like the neutrophilic dermatoses.
Looks a lot like the neutrophilic dermatoses. So you have newts, caryorhexis. It's a big, broad, sort of nodular and diffuse. You got papillodermal edema. So what are your neutrophilic dermatoses?
You have sweets, bowel bypass, the autoinflammatory disorders.
Actually, we haven't mentioned the whole family of autoinflammatory disorders, PAPA and SINCA and all of those things. So if you've got ANCA or osteolytic lesions and it started when you were young and you've got pain or serositis and fever, you're in a familial Mediterranean fever type of differential, and you just go to OMIM and you type in everything they've got and it'll tell you your differential. So sweets, bowel bypass, PG, which is what this was again. But it could be any of them. Pustular dermatosis of the dorsal hands, GCSF, autoinflammatory, they're all in the neutrophilic dermatosis realm. Let's see. That's in the wrong box. Okay.
This one's a little bit thick, I don't know, quite acral. This is like a superficial infiltrate.
So it's predominantly around what vessel?
Looks like more of a capillaritis.
Looks like a capillaritis. You also have what?
A little bit of spongiosis, tagging.
And a little bit of tagging. So what's your different, and papillodermal fibrosis. So what's your differential?
Like the PPD, like MF, or
yeah, I mean that would be your rule out. This is either PPD or this is MF that looks a lot like PPD. That's your differential. And then you've got to, go through an MF workup and also take a look at the patient because that'll usually help.
So in the superficial dermis, looks like I was trying to make out what this was.
Let's go a little higher.
This looks like nudes.
Yeah, nudes.
Mostly nudes, but.
So nudes in a lot of mononuclear cells too, right?
Mm-hmm.
And papillodermis.
A little bit of edema.
Yeah, and is it strictly perivascular or is it more band-like diffuse?
More band-like. So with papillodermal edema, nudes, you would think about like a sweets.
And which of the neutrophilic disorders has a mononuclear variant?
Let's see.
It's sweets is the one that does. And mononuclear sweets, a lot of them are actually leukemia cutis, right? Where those mononuclear looking cells are, they're just immature leukocytes. But a few of them, they've done gene analysis, and it's not the leukemia. There are other immature cells being produced, but they're not the leukemic cells in some of them.
I think perivascular infiltrate. I see some EOs definitely around.
And you're starting to get some stuff on the collagen.
Yeah, you mean like caryorhexis or like degranulating eosinophils?
Like degranulating EOs.
So
it's like an early wells. So, we've seen the whole spectrum of wells pretty much. How are we doing time-wise? We're still good.
lots of extravasated reds.
With lots of inflammation, right?
Nope.
Nope.
No inflammation.
Oh, I got that wrong. Damn. Okay, so if there's no inflammation, then what's your differential?
So senile purpura versus like some kind of thrombocytopenia.
Yeah, and so the next thing you do is you look at the vessels. Any thrombi in the vessels?
They look pretty clear.
Yeah, vessels in this are clear as a bell. So if it's all perifollicular and you've got corkscrew hairs, then you got scurvy. This, you got very atrophic skin with solar elastosis. This is probably what we politely call actinic purpura, which is senile. It's just, the patient doesn't want to be called senile. Yes, you, sir, have senile purpura. Have a nice day. Okay.
So it looks like there's a lot of inflammation.
Okay, so post-capillary venial?
No, like deeper than that.
I keep getting them wrong. Okay, so what is this?
Part of like LCV, part of the Big Five.
So how big is the vessel?
Pretty big.
Real big.
Yeah.
And what kind of vessel is it?
It looks like an artery.
Yeah. So what would be a big arteritis in skin?
Like temporal arteritis.
Yeah, temporal arteritis, although a biopsy of TA never looks like this, right? Because a biopsy of TA is a temporal artery biopsy, which is going to be little round things because they take that temporal artery and they cut it into little round circles.
Okay.
So you got 20 little round circles on your slide, that's a TA biopsy. Okay. So this is more likely to
So
be...
like PAN.
Yeah, PAN. It was a patient who presented with livido and got a biopsy, and that's polyarteritis nodosa. So there is lymphocytic macular periarteritis, which is livido, and it's all lymphocytic, and that's early PAN. So those people evolved to PAN. So the lymphocytic macular periarteritis is, anything that looks like PAN is PAN. Follow them. So, they keep giving different names to people who look like they're not quite PAN and they don't have kidney disease yet. Just follow them along. They will. Okay, and that's in the wrong box. Okay. So that's the skin, right?
Okay.
And then here you got the edge of an ulcer. And what do you have going there?
So it looks like, is it mucin in there?
Yeah, well, it is myxoid, and then it's just a huge cannonball tuft of vessels, right?
I see.
So where are you and what caused the ulcer most likely, given that there was all this tufting too?
So I'm looking for, is that extravasated red?
There's lots of extravasated reds.
So probably like stasis change.
Yeah. So, this is all stasis change, probably a stasis ulcer. Almost anything reparative on the shin. If you do a re-excision of a squame biopsy, it's going to have some of this tufted angioplasia on the leg too. It's just the way leg heals, is it heals with tufted angioplasia. So it tells you got something reactive on the shin, which is often stasis. Okay, let's see what we got.
Looks like we have superficial perivascular infiltrate with eosinophils.
And
Neutrophils also.
yep, is there karyorectic debris?
Yes.
There is. So this is Still's disease, right?
No. Yes.
You tell me. Is this likely Still's, yes or no? There's karyorexis.
No.
That's not so Stillsy, right? Still's is the neutrophilic disorder that's like urticaria, where there's no karyorexis. When you've got karyorexis, you're probably vasculitic. Okay. So the whole thing that defines urticaria and stills and the other, neutrophilic dermatoses that, like E. marginatum, they don't have karyarexis. This does have karyarexis, so it's probably evolving vasculitis. Vox. Okay.
So it's pretty superficial. Infiltrate.
So pretty superficial, meaning is that vessel predominantly involved, or is that vessel predominantly involved?
So I'd say it's probably in the capillaries.
So it's a capillaritis, and it's a neutrophilic or lymphocytic?
Lymphs.
So it's a lymphocytic capillaritis, and there is red stuff, which are RBCs, and there are tiny little bits of brown stuff, which is probably...
Hemosiderin.
So this is...
PPD.
PPD, and what do you have to look for in PPD?
You want to make sure it's not MF.
Yeah, and so here you've got that one angulated big lymph sitting there. Just one. But that's probably enough to make you do additional biopsies and take a look at the patient. Because you shouldn't usually have a big, hulking, angulated lymph tagging at the basal layer in PPD. So that's a clue that maybe you would need to look a little closer at this patient.
What percentage of derm paths that read that will comment on that?
Every last one. I mean, they should. So, some of it is plain dissection. You may have missed that, right? Which is why you'll read lots of reports of people followed as PPD who turned out to be MF. It means you just didn't appreciate it in the initial biopsies. Okay. So, Derek, how about this?
Looks like we're on the acral surface.
Yep.
So there's an inflammatory infiltrate in the papillary, reticular dermis, perivascular.
And it's all neutrophilic, right?
No.
So what is it?
Lymphocytic.
Lymphocytic. And are they overlapping or are they pretty discrete?
Seem to be pretty discrete.
Some acral skin, very discrete lymphs, perivascular.
Perniosis.
Yeah, probably.
I think I'm in the Wells.
Yeah, exactly. So that's about as Wellsy as it gets, except that, what are these?
Oh boy.
Ooh.
Churg Strauss were nice guys.
Yeah, exactly. So this one has some histiocytes around it. You better look at the patient because this one actually could be Churg Strauss, right? And so Wells, what horrible things happen to you with Wells?
Itch.
Itch. Yeah, it's about as bad as it gets, right? With Churg Strauss, what happens to you?
A lot of internal problems. Lots of kidneys. Is it lungs
Kidney,
too?
not so much lung.
That's Wagner's more so.
Brain. So you're going to have vasculitis that's cerebral, kidney, and what usually kills. So Churg Strauss people are often 18, 19, 20 years old, and what do they die of? MI, coronary vasculitis. So, really, that's what Churg and Strauss. Strauss, I think, was the woman dermatologist at Mount Sinai, and Churg, I think, was the pathologist. And together they described, they were these young New York people who were dying of fulminant vasculitic syndrome with these funny granulomas. So, and dying of MIs in their 20s. And so they looked at it and thought, maybe something's amiss. Right?
It's super and deep,
Superficial and deep.
and the infiltrate with the eosinophils and lymphocytes.
Yep.
And so,
How about the lumen of the vessel?
oh, it's swollen.
Yeah.
That means it could be some drugs relation or syphilis or
Or the other thing that's superficial and deep, polymorphous with EOs and lots of endothelial swelling.
PREVA.
And yeah, arthropod.
Oh, sorry.
Arthropod, bug bite is the other big one in that category. Okay.
I think epidermal is no change.
Oh, lack of epidermal change. I
yeah.
see. Often you have epidermal change as a clue in bug bite. That is true. This one didn't have it, so I can see how that made you question it. You don't always see the epidermal change. That's often plane of section.
Thank you, sir.
Okay, but that's a very good observation, that the epidermal change is one of the things that distinguishes bug bite from other DHRs, because they usually don't have an overlying epidermal spongiosis. Whereas the bug bite, if you actually get the site of the bite itself, that helpful clue is the overlying epidermal change.
Looks like a scale crust. Probably facial skin.
Scale crust, facial skin.
Mixed infiltrate, mostly lymph, so.
Yeah, it's mainly lymphs.
And I can't tell if it looks more diffuse, like not
There
necessarily
are
around a
plasma
vessel.
cells here too. And there's cytoplasm to the lymphs. So syphilis is probably the first place I would go with this and make sure we've tested for it. This is an actinic parigo.
Go back.
Thank you, sir. Actinic parigo and an Amerindian. So the actinic parigo, you need the clinical. They've got big swollen lips and edema and papular eruption, predominantly face, but also hands, other exposed areas. And, it's almost always Amerindian, whether it's North or South America. So they have indigenous American blood, as well as Spanish and Caucasian or whatever else is mixed in. And the ones that are superficial like this are benign, and the ones that are in the sub-Q fat, about half of them die of lymphoma. And they're usually EBV, whether they are ultimately malignant or benign. The fat ones are usually EBV. And now, they're called hydroa-like, it used to be called hydroa-like lymphoma and hydroa vacciniforme. Now they're all hydroa-like lymphoproliferative EBV associated, because any of them can die at any point. So I think you see maybe in the morning slides the little girl that the mission trip, the guys from Michigan went down, and little girl with swollen lips and face and necrotic lesions on arms and legs, all in the fat, rimming of the fat. She was placed on chemo there, and had an initial remission, and then fulminant recurrence and death. And the just published just presented at the ASDP from the Latin Americans, where chemo seems to make the course worse. So at some point we'll have something to treat the EBV directly, but their chance of dying is greater when you treat them with chemo. So, that's sort of like what you see with MF too. Is MF, you live as long as your immune system keeps it in check. And chemo, although it gives you short-term remissions, it blows away your immune system, and it's not doing you a favor in the long run with MF, which is why there are new targeted therapies and things, but traditional chemo always worsened the outcome for MF patients. Okay. So where do you think you are?
Probably April.
Yeah, somewhere acral, right?
And gonna have like an onion skin fibrosis picture.
So onion skin fibrosis around vessels on an acral site. What are you thinking?
Looks like ED.
Erythema elevatum diutinum, which is associated with.
HIV.
So HIV is.
Lupus, other things.
So HIV, strep, paraprotein. Not so much lupus, but certainly HIV, strep, and paraproteinemias. A lot of them are plasma cell dyscrasia. And they're funny, like some of them are IgD and funny things like that. Okay.
Deeper in the dermis.
There's all that hemorrhage, and that may actually be biopsy in this case.
Okay.
So, but you'd wonder about a non-inflammatory purpura. But what else do you have superficially here?
So perivascularly, it looks like you've got, or actually more so within the lumen.
Within the lumen?
Yeah, so looks like lens.
What's the red thing?
Oh, EOs.
EOs, and what are the things with segmented bodies?
Newts.
So newts and EOs in the vessel. So what spectrum are you in?
So you could be in like urticaria.
Yeah, so it's an urticarial type reaction.
E. marginatum or.
So urticaria, E. marginatum. Urticaria tends to have, well, one history is going to help you, but urticaria tends to have more EOs than the other neutrophilic ones. They can get EOs, usually a little bit less. The things like E. marginatum. Okay.
I think we're over time, Dr. Elson.
We are. Yep. Gotta quit. I got patients waiting downstairs. Thank you.
That's on your schedule.
I'm sorry?
You have a meeting at 8:30. That's on your schedule. It's booked off from 8:30 to
Oh, I
9:30.
do this morning. I have. It's, yeah. Thank you.
You're welcome.
Because that would have been really bad. So,
Thank you.
yeah, my clinic actually starts at 8:15.
Yeah.
Okay.
Because yeah, it's a strategic planning thing. Thank you.
You're welcome.